So I know that you guys are in a patient assessment class, and you will cover some of the grounds in cardiac assessment, but it's very important to understand a cardiac specific assessment, so we're going to hit the stuff that's specific to cardiac so that we can see the overall picture. When we get ready to manage a cardiac patient, there's going to be a lot of stuff that goes into it, okay? You know what the common complaints of cardiovascular system is? Don't think we need to get real deep into that, huh? So, just taking it way back, whenever you get to your cardiac patient, you're going to have to form or observe your general appearance. A cardiac patient that's a true cardiac patient may not just jump out and say, hey, I'm having a heart attack, right? Cardiac symptoms mimic a lot of things. What's one of the most common things, especially in men? Indigestion. What's one of the most common things in women? Back pain, nausea, vomiting. I had a patient in the ICU last semester that she had the big one. She had a almost 100% occlusion of her LCA that she was out raking leaves and thought that she had pulled a muscle. And the only reason why that she came to the hospital is because the muscle pain wouldn't ease up and she was nauseated and she was yakking. Luckily, the ER doctor that was on that night didn't just chalk it up to muscle pain. They did a 12-lead on her and she went straight to the cath lab. And she was very lucky because had she waited, she probably would have died. Because the left coronary artery, you get a block in that, that's also known as the widowmaker. That's right. As always, we're going to assess for apparent life threats with a cardiac patient, a cardiac dysrhythmia, a patient that's having some type of ACS problem, or that's even going into cardiogenic shock. That is a life threat, right? What are some of the things that we may see on a critical cardiac patient other than just being pulseless and atonic in cardiac arrest? Real diaphoretic, obviously chest pain, right? Hyper or hypotension. Bradycardia, tachycardia, rhythm irregularities. When we get on into rhythms, you'll realize that there are some rhythms that are more lethal than others that if we see on the monitor, it's oh crap, we need to do something quickly. And then of course, determine level of consciousness. If they're responsive, we're going to check a radial pulse. Unresponsive, we're going to check a carotid pulse. Now, here's the thing about a cardiac event. They may be responsive, but if their ticker isn't ticking right, they may not have a very good radial pulse. So if I've got a cardiac patient that I believe is having a true cardiac event, I may go on and check a central pulse as well and even compare the two. Because if I've got a stronger central pulse and a weaker peripheral pulse, what does that tell me? Yeah, that we're not perfusing to the extremities. We're not perfusing to the periphery very well. Regularity, rate, overall quality, we'll be able to tell a lot of that just by the rhythm of the pulse. We talked about a little while ago, the heart is designed to have a rhythmic fashion, right? It is designed to go in rhythm. So you know what a normal pulse feels like, right? And so you should be able to feel if we're having irregularities. And then skin color and condition, because that's going to be a good overall indicator of what? Perfusion status. No question about it. There's just some things that you don't have to sit there and make a decision about. If a person's having a cardiac event, even minor in nature, we need to immediately transport. Because what do we know about ACS and cardiac events? What do we know about them as far as progression? It can progress very quickly. And so our main goal, no matter if it's cardiac, respiratory, anaphylaxis, no matter what it is, as pre-hospital providers, is going to be to stabilize, and in stabilizing, we're trying to stop the cascade of the event and try to get a somewhat normal homeostatic balance and get them to a higher level of care, right? If you believe that it's a cardiac event, but you're not sure, go ahead and treat it as such, all right? The old saying, prepare and expect the worst and hope for the best, right? You owe it to that patient to go ahead and be prepared for the worst case scenario. The OPQRST, as y'all have learned in doing your assessment stuff, doesn't always go with most everything, right? Chest pain is really what the OPQRST is really good for, because we need that information, right? We need to know how long it started, because we've got a window to do what? To get them fibrolytics, right? We've got that window to get them to the cath lab. All right? We need to know if it's radiating. We need to know the severity of it. Why do we need to know the initial severity of it? So we have a baseline. That's exactly right. We got to have a baseline. Just like with any patient, we've got to have a baseline so that we can tell if things are getting worse or better, to see if our interventions are getting or are helping. And as paramedics, we're going to be doing a lot more interventions. All right? And so we're going to have to continue with that ongoing process so that we can see if our interventions are getting better. Dyspnea is another chief complaint of ACS. Why would dyspnea be an indication of left-sided heart failure? Okay? Think about more of not necessarily perfusing the whole body, but just think of the whole mechanics of the left heart. Just think on the very basics. If the left heart ain't pumping, what's happening? We're starting to get pulmonary edema, right? And so we're blocking the external respiration, right? And so we're going to start having shortness of breath because we can't oxygenate. All these questions, you know these questions. I don't think I need to go through all that. Fainting. Fainting associated with ACS. Why? Why would fainting be associated with ACS? Okay. So it's all part of the perfusion, but it comes back down to cardiac output, right? Everything in this class is going to come back to cardiac output and alterations in cardiac output. The noggin needs what? Oxygen. If we've got heart failure or if we've got poor cardiac output due to some type of coronary syndrome or any other kind of myocardial problem, then we may faint. So you've got to ask any of all these questions if they have fainting, all right? Because we also know that fainting can be caused by other things too. And like I said in the beginning, a person may think they're having a cardiac event, and in turn it may just be something else. But again, we expect the worst, right? We prepare for the worst and hope for the best. My favorite example of this is I had a 18-year-old boy that swore up and down he was having a heart attack. I mean, he was just doubled over in pain. I mean, had he been the prime candidate, I would have thought that he had a heart attack. It all boiled down to he had smoked some bad hashish, and he was feeling like crap from doing bad drugs. All right? So you got to look at your overall picture. I'm not saying that ACS can't happen with young people, because it can, but more often it happens with people that's had the effects of life on them, right? The stressors of life. What's a palpitation?
Feel your heart beating through your chest.
Yeah, palpitations, just when you feel that extra. What do you think the most common cause of a palpitation is? Do what? Caffeine, but what does caffeine cause? PVCs. Most often, that's where folks are going to feel that fluttering or that just real strong beat, those palpitations. Usually from some type of stimulant, smoking crack or drinking Coke. It's one of those two. It's either Coke or crack, right? Or Red Bull, I guess. Want a Red Bull? You got a Red Bull? It's a movie reference.
I can count my heartbeat when I lay in bed.
Can you?
I'm serious. And I had another question too.
Hey,
Why when I sit down and do my heart rate goes so low?
you're athletic, I guess. I don't know.
Not athletic.
Maybe your intrinsic resting heart rate is just low. I mean, if you don't feel like you're about to die, that's... All right. Patients may also report feeling of impending doom. Anybody that's worked in the field for a while knows that if a person is having a true ACS event, that feeling of impending doom isn't just in their head. The body knows when it's about to go out. We've got to take that seriously, right? Now, I didn't believe for a minute that that 18-year-old was about to die of a heart attack, because I'd hooked him up to the monitor and all that. Not that I didn't believe him. I am compassionate. But if a person that's having a true cardiac event is telling you, hey, something bad's about to happen, you can bet your bottom dollar that if you don't intervene, something bad's about to happen. And this goes all the way back to EMT. What do we never tell a patient? You're going to be fine, or everything's going to be okay. What do we tell them? We're doing everything that we can. You've got to do everything that I ask you to do, and we're going to get you to the hospital. And then we talked about nausea and vomiting. Inquire about a medical history. It goes without saying, right? I said it anyways. The next thing that we're going to talk about is just some of the home meds. Why is it important, especially now, being the primary caregiver in the field, to have an understanding of home meds?
Because of the patient sometimes you can look at underlying problems that you might not know about.
That's right, that's right. So when you do pharmacology in paramedic school, you're learning your drugs that you're going to give. It's very important to learn those, but it's also very important to learn these other classes of drugs. The example that I always give, you've got Miss Jones as an 80-year-old female patient of Dr. Fuller. Go up to Miss Jones and say, hey, honey, or don't say honey, but say, hey, Miss Jones, you got any medical problems? In her mind, she doesn't, because Dr. Fuller's doing what? Taking care of her. Or, what kind of medical problems do you have? Oh, I don't know, but call Dr. Fuller. He knows. And then you say, okay, well, you don't have any medical problems, so you don't have any meds. You got your meds, and she gives you that black garbage bag full of medications. If you have time, simply by going through those medications is going to help you to at least kind of get a basic understanding of the medical history, and a good understanding of the medical history can give you a good understanding as to what's going on with them, right? So these next few slides, we're going to talk about a couple of the home meds, and as far as how they relate with cardiac. Patients may be taking a wide variety of medications. Polypharmacy. You know, especially older individuals or unhealthy individuals may go to the kidney doctor and the neurologist, and may go to the cardiologist and the endocrinologist and all this, and they're all prescribing different medications. And do you really think that the doctors get on the phone with each other and say, hey, what you got Miss Jones on? No. And so some of these medications may interact with each other, right? Now, it's not always possible to identify the problems based on medications, but it can give you a good idea. So this first drug, digitalis preparations, more commonly known as DIG. You'll hear it as DIG. Digitalis is a medication that a chronic CHFer will take. It's also a medication that people with atrial fibrillation, dysrhythmia, will take. So one of the properties of DIG is that it increases cardiac contractions. Why would that be important for a CHFer? Right. The cardiac muscle needs a little extra help to get that cardiac output out, right? So it would actually be a positive inotropic agent. Did we talk about those terms last week? Inotropy, chronotropic? Okay. Here's the problem with digitalis. I know, for the ones that didn't have my advanced class, I'm sorry I keep referencing this, but I hope that you guys talked about it too in pharmacology. Remember when we were talking about pharmacology, the therapeutic threshold, right? The therapeutic range? And some medications has that wide range, and then some medications have that real narrow range where it's therapeutic or it'll kill you, right? Or you become toxic. Digitalis is one of those medications that it's either therapeutic or just above that is toxic. So 30% of patients may develop toxic effects from it. So you may actually go to a patient that is overdosed on digitalis, and there's certain signs and symptoms that that you'll see. One of the most common is a halo or blurred vision. And then also you'll see some cardiac dysrhythmias, I think a prolonged QT interval and things like that. And then this last part, will be sensitive to calcium preparations and have a decline in potassium levels. Nitrates, what's that? Nitroglycerin is one of the most common ones. Nitrostat, what? Nitrobid? Yeah. So not all patients are going to have just the spray that you put under their tongue or the pill that you put under their tongue. Because nitro isn't just for chest pain. Now, most of your cardiac patients are going to have nitro for acute angina, right? They start hurting, they're going to pop a pill, right? But what do we know about nitrates? What do they do to the vascular system? They're a potent vasodilator. So some patients may actually have a skin patch that they put on that has the cream on it that delivers just a continued dose to help with vasodilation. What's the problem with that? They may put too much on, or they may have taken their other hypotensive medication and that beta blocker is working really good, or that ACE inhibitor is working really good, and now we're continually getting this prolonged amount of nitro, and they're hypotensive. I don't think I really need to get into a whole lot. Y'all should understand nitro pretty well, right? It's one of your AMT medications. Another nitrate is isosorbide dinitrate. You'll most commonly see that as Isodil. Beta blockers. Now, beta blockers are used as an anti-anginal, also used for slowing down the heart rate, also used for high blood pressure. A beta blocker does what? It blocks the beta adrenergic receptors, right? What do the beta adrenergic receptors do? They're part of which nervous system? The sympathetic. So they speed everything up, right? Contract a little bit. So a beta blocker is going to block that that receptor. The reason why it's going to be an anti-anginal agent is because it's just going to take the cardiac workload off. If it decreases the strength of contraction, and if it decreases the heart rate, the heart's not going to work as hard, right? And it also says it may lead to the resistance of beta-stimulating agents. Epinephrine. Albuterol. You take a beta blocker, and then you take a selective sympathomimetic, they're going to kind of collide, right? What do you notice about the beta blockers? They're all laughing out loud. Ha ha ha. They're laws. Now, not all beta blockers, you're not going to see all beta blockers in their generic form, but your generic beta blockers are going to have this LOL at the end. Now, you may see it in the trade name, Inderol or Trandate or any of these, but if you have a medication and you see labetalol, you're going to see that LOL and you're going to think what? Beta blocker. Calcium channel blockers. So we kind of understand what calcium does to the cardiac cycle now, right? So what do you think a calcium channel blocker is going to do? Okay, so it's going to block the influx of calcium ions into the cardiac muscle, which, what does that do? What does the cardiac calcium do to the cardiac muscle? Contracts. So really and truly, it's going to take the workload off of them because it's going to decrease the work. All right? Pretty cool. Now that you understand how the cardiac system works, you can kind of understand how the medications work, right? You should. This is the common suffix for calcium channel blockers. PINE, pine. Amlodipine, felodipine, narcotipine. All these, okay?
So is the calcium channel blocker and the beta blocker, they essentially do the same thing? They're both anti-anginals, they decrease workload on the heart.
Right.
So they essentially do
the same thing, but they're acting on different areas of the heart. That's why you've got so many different blood pressure medications. That's why you've got so many different other kinds of medications. Yeah. Yeah. I mean, not everybody can take a beta blocker and it bring their blood pressure down. Not everybody could take a calcium channel blocker and it bring their blood pressure down. All right. So those are just a couple of the anti-anginal or and also antihypertensive meds. Your antidysrhythmics. DIG, we just talked about that. What was that? What did it do? Why would somebody at home be on DIG? CHF or even AFib, things like that. This medication and lidocaine you need to get familiar with because that's going to be meds that you give, all right? Usually folks aren't necessarily going to be on lidocaine or procainamide. Procainamide is a little bit older medication. If they've got a dysrhythmia, usually they're either going to be on amiodarone or digoxin. Do what now? I don't know. Yeah, I don't know. Diuretics, what do they do? They make you pee. What patients would be on diuretics? CHFers? Alright, some cases renal, not a lot of times renal. They may be on some of the potassium sparing. So basically the idea behind a diuretic, especially like a loop diuretic, is, and that's going to be Lasix, which is going to be on your drug box, furosemide, or even Bumex when they run out of Lasix, is that we know that water follows what? Sodium. So what a diuretic does, without getting real deep into it, because I can't, it pulls the sodium out, and in turn, the water is going to follow the sodium, right? But the problem with that is that potassium doesn't want to be left hanging, and so it's going to go to the party too, and so it will pull sodium and potassium out. Why would that be a problem for a cardiac patient? Yeah, because you need potassium. It is a primary electrolyte for depolarization. Isn't it cool how you know that now? I think it's so cool. I ain't kidding. So patients that are on loop diuretics, and even some of these others, they may be also on potassium supplements as well. Antihypertensive agents, these are going to be your beta blockers, your ACE inhibitors, your angiotensin converting enzyme inhibitors. Where does the angiotensin, renin, angiotensin, and all that, where does that occur? In the kidneys. In the kidneys. So your ACE inhibitors are going to be prils. P-R-I-L. All right. Some of these are alpha agonists or alpha blockers. So, again, just kind of have an idea, really, of the suffixes and just a little bit of an idea of what they do. Really, angiotensin converting enzyme inhibitor is going to block angiotensin 1 from converting into angiotensin 2. If you want to get deeper in that, look it up under the renal chapter. Anticoagulant drugs. What's the difference in an anticoagulant and an antiplatelet? Yeah, an antiplatelet isn't going to bust the clot up, right? The antiplatelet's just pretty much, for lack of better words, going to lube up the platelets so that they don't stick to each other. An anticoagulant, more affectionately known as a blood thinner, aspirin's not a blood thinner. Anticoagulants are blood thinners. Your antiplatelet medications, the first one that comes to mind is what? Aspirin. Then you've got Plavix, this, I don't know, I've never seen this listed. And then there's another one, no, it's anticoagulant. Your anticoagulants, the most common one that you're going to see is warfarin, also known as Coumadin. But there's this new one called Pradaxa. The doctors and the patients, they prefer the Pradaxa now over the Coumadin because a person that's on Coumadin has to go have their PT and INR drawn weekly. They have to have blood drawn weekly to make sure that their clotting factors aren't getting messed up. All right? They got to make sure that they're not clotting too easy, and they got to make sure that they are not clotting too easy. So this Pradaxa is a new medication that keeps them from having weekly blood drawn. Digoxin, it's a cardiac glycoside is actually the category of drug it is, but it has the dysrhythmic properties and also the inotropic properties. Then some of your vasodilators. Hydralazine is a common one. All your statin drugs. Statin drugs. These are going to be cholesterol-lowering drugs. Niacin drugs, they're cholesterol-lowering drugs. Problem with niacin is that people get really, really hot and really flushed when they take those. Anybody ever drink a 5-hour energy drink? When you drink it, do you kind of get a little hot, like a warm feeling over you, or a flush? Somebody in here. Well, I do. If y'all are going to ruin it, I do. It has niacin in it, and it may be in my head, but I see niacin on the bottle, and I get real flushed and all that.
It just makes it a little
That's right. The level of consciousness is a good indicator of cerebral perfusion, right? We know if their noggins getting perfused, if they are unresponsive or if they've got a lot of anxiety, we know that it's not getting perfused as well. The physical exam. Now this is not, we didn't spend a lot of time in advanced EMT, and I don't know if y'all did in your advanced EMT as far as like doing a actual physical exam, listening to heart sounds and all that kind of stuff. This is what this is getting into. First off, we're going to inspect, auscultate, and palpate. We're going to look at the neck and the tracheal position related to the heart. What is the tracheal position and distended jugular veins going to tell us? Yeah, maybe some heart failure, right? Also, can you see an implanted pacemaker or an implanted defibrillator?
Yes.
Yeah, you can for the most part. Unless it's a very, very large person, and even then, it's very superficial, so you usually can see it. So be looking for it. Usually it's in the upper left part, and it's obvious. It's just this big box under the skin. Also, it could be on the right side in some situations too. Look for surgical scars. A surgical scar, somebody that had their chest cracked, that's going to be a good indication that, hey, they've had what? A cabbage in the past. You're an expert at that, aren't you? Not that he's had heart surgery. He used to work at CVICU. Look for a nitro patch like we talked about. Chest enlargement. Crepitus, if they're trauma. We're going to listen. We're going to listen with a stethoscope. When we're listening for S1 and S2. What is S1? S2 is dub, lub dub. What is that? What are we actually hearing? Yeah, we're actually hearing the heart valves. We're hearing S1 is the closure of the mitral and tricuspid valves. And then S2 is the closure of the aortic and the pulmonic valves. When do the mitral and tricuspid valves, when do they open? At the start of systole, right? At yeah, that's right. And then when would the aortic and pulmonic valves close? After the ventricle is contracted, right? After it's got the blood out. So we're going to listen to the apex of the heart. That's going to give us our lub. And then a little bit more over here, we're going to hear S2 because remember, you're going to listen about the area where your valves are. S3 is a da and S4 is a blah. S3 is an abnormal third heart sound. S4 is an abnormal fourth heart sound. And there was something that I wanted to tell you all about this. Where to go? So S1 occurs near the beginning of ventricular contraction. These valves should close simultaneously. So we shouldn't hear like a lub lub dub dub. We should hear a lub dub. All right. Sometimes they may be off just a little bit, but we should not hear the mitral valve close, then the tricuspid valve close. Does that make sense? Yeah, it does. The sound should correspond to the pulse at the carotid artery. Makes sense. The sound of the tricuspid valve closing may be louder in cases of hypertension. S1 may be louder in patients with anemia, fever, hyperthyroidism, as well as patients with stenosis of the mitral valve. Decreased S1 sounds, you may want to write this down, can include mitral valve that is calcified or subject to fibrosis, obesity, emphysema, and cardiac tamponade. Why is cardiac tamponade going to cause decreased heart sounds? Right, you can't, there it is right there. You can't hear it because you've got the fluid that you're having to go through. A split sound from any delay in the closing of both valves is considered abnormal. S2 corresponds with the pulmonary and aortic valves. They close because of the backward flow into the pulmonary artery and into the aorta. Normally close simultaneously or with a slight delay. Sound will be louder in patients with chronic high blood pressure or pulmonary hypertension. The sound will be decreased in patients with hypotension. The sound may be split in the case of a right bundle branch, resulting in a delay in pulmonic valve closing, so problems with the electrical system. And the aortic valve may close more slowly than the pulmonic valve in situations involving the left bundle branch block. S3. It is caused, or S3 is an extra abnormal sound in adults caused by ventricular wall vibrations resulting from a rapid filling period of the ventricle during the beginning of diastole. When heard in older adults, it may indicate heart failure. And then S4 is a rare heart sound, indicates the turbulent filling of a stiff ventricle, or also MI. I'm not expecting you to become experts on these sounds and these murmurs and things like that. Here's a couple of the other abnormal heart sounds. Pericardial friction rub is not a good thing. It sounds like sandpaper. And that's because they've lost that fluid. Pulse, we know what a pulse is. A weak 30 pulse could indicate a decrease in cardiac output, right? A rapid pulse could be due to anxiety or pain. A rapid pulse, we're not going to have good cardiac output because it's not going to allow the ventricles time to feel. May have a pulse deficit. This is going to be where the radial pulse is less than the apical pulse rate. Again, problems with perfusion, cardiac output. Pulsus paradoxus, this is an excessive drop in systolic pressure when somebody's in between systole within 10 seconds. They may drop 10 millimeters of mercury. pulsus alternans. Alternates between strong and weak beats and is indicative of left ventricular systolic damage. Blood pressure. In order for the body to perfuse good, we've got to have what? Good blood pressure. Y'all know what the good systolic blood pressure and good diastolic blood pressures are, right? What is mean arterial pressure? It's a difference between the systolic and the diastolic blood pressure, and it's really the average blood pressure that perfuses the body. All right? The brain needs a mean arterial pressure of at least 60 to perfuse the head. So elevated blood pressure could be some type of problem, blood pressure issues, or anxiety or pain. Blood pressure could be reduced if we have a reduced stroke volume. Stroke volume is the amount of volume that's coming out of the ventricle every stroke, right? This could be problems with preload, such as with hypovolemia, or it could be cardiac tamponade. Why would cardiac tamponade reduce stroke volume? Because it won't let old Frank Starling work, right? It won't let it stretch to force it out. Or cardiogenic shock, we just got a poor pump. We're going to get into monitoring devices next week.